Hello class. Today we're going to talk about theory. And what is theory? Well, we're going from a big K, as in capital K knowledge, which is nursing knowledge, down to the various levels of theory, from broadest here down to what you see as situation specific, which is the most narrow level. Now we look from nursing knowledge to the goals of our discipline, which include facilitating immunization, meaning, choice, quality of life, and healing and living and dying, to down to our domain derived, which would take us down to that situation specific theory. So it's just one way, and that's Sister Callisto Roy's way of envisioning how you can put everything we do within nursing knowledge into one model, which is of course not easy to do. So what exactly is theory? Well, it's a way of seeing through a set of relatively concrete and specific concepts and propositions describe or link these concepts. And think of a proposition as a simple relationship. A leads to B. Theory is an internally consistent set of concepts, constructs, definitions, and propositions that give us a systematic view about a phenomenon that's useful for description, explanation, and prediction. That's what theory does. It allows us to describe, explain, and predict. And the purposes for theory for nursing, it gives us an organizing structure which we use to store the substance or the knowledge of nursing. It gives us a basis for practice, a source of professional identity, coherence of professional purpose, and a method of communicating to other disciplines, and consequently directs research. It's basically a way of thinking through a problem and identifying possible causative events, correlations or relationships, and of course outcomes. So when we organize theories, and this is a progression of broadest, which is the grand theories, down to the narrowest, the most specific, and those are single domain theories. So the largest, most broad, and in this case untestable, are grand theories. Then there's middle range, which can be tested in some ways, and single domain, which are very testable. A grand theory is highly abstract, has a very broad scope, and relationships can be presented in a common way through narrative, and some grand theories are not so much common sense. They are not testable, and that's one of the reasons you will not be using grand theories in your wikis. They are not testable and consequently cannot be operationalized. And to actually test a grand theory, you've kind of got to create a middle range theory component within it. A discipline such as ours can have a number of grand theories. And each may present a different way of viewing the phenomenon of concern for a discipline. Now remember, our phenomenon of concern, in this case, is our metaparadigm. That's nursing's phenomenon. And each can contain very different language and different methods of research. So nursing, we have dozens of grand theories. You'll find that some schools or colleges of nursing have adopted a particular grand theory to guide them. Some magnet hospitals have actually also chosen grand theories to guide their work. For those of you who work in magnet hospitals, you may be familiar with them. And they're going to have different ways that they recommend that you practice and actually work through things. An example of a grand theory is Leninger's sunrise model. Note the broadness in this sunrise model deals with culture care. And this over on the right is just the citation of where you can find that, if you want to learn more specifically about this model. But you'll notice in this particular model, you start with a worldview. So she actually starts with a meta paradigm, if you think of it, and takes it down to the cultural and structural social dimensions, all the way down to the individual level in that center of the model, as well as beneath it with the families, the individuals, the groups. Takes it starts from very broad and takes it down to individual. But this has so many different connecting paths. And notice all the bidirectional arrows in this particular model, which makes it very difficult to test anything to find out what causes what, particularly when there are so many variables, or in this case, propositions in this model, and so many concepts. Now, when we look at a middle range theory, this would be that middle level. So it's complex than a single domain theory, but it's more focused than a grand theory. It has more concepts and more relationships, and applies to a wider domain of nursing practice than a single domain theory, but it actually deals with practice, whereas a grand theory doesn't necessarily do that. It has propositions which allow for testing of relationships. So middle range theories are testable. So an example of a middle range theory is June Johnson's self-regulation theory. Johnson's theory says there's a discrepancy between expected and experienced physical sensations. So what is felt, seen, heard, tasted, and smelled during a threatening experience. That discrepancy will result in distress. And where she used this was actually in pre-op. She found, and based on her theory, and it was tested, that informing a patient about what they'll feel, see, and experience prior to a threatening event, such as surgery, increases their cooperation and decreases anxiety about those events. It also is going to help them be more cooperative and more, I hate the word compliant, but more adherent to what needs done in the post-op as well as the recoveries. To us now, this seems pretty common sense, but when she originally developed the theory, which was way before 1999 in that citation, but that's a current testing of it. She actually, this was new news. People hadn't thought of doing that. They thought they would scare the patient to increase anxiety and will result in negative outcomes. Basically the opposite of what actually came to be. So single domain theories, this is the most narrow, very narrow, and pertains to a very circumscribed area of nursing practice. Single domain theories can also be called situation specific theories, which if you think about it, if it's just one domain, it's just going to apply to one situation. So you can see why those would be synonyms there. And example would be like Bayard's theory. See how it just applies to a specific instance. Well-being in refugee women experiencing culture transition. So just deals with well-being in a particular population, refugee women, during a particular experience, which is cultural transition. So super specific. Additionally, when we look at Willis's theory, moving beyond dwelling and suffering for men after childhood maltreatment. So you've got population, again, men, and who are returning or being resilient beyond the suffering experience that they had from prior childhood maltreatment. Very, very specific. Now, the Nursology link will take you actually to the Willis specific theory, but Nursology.net is a wonderful resource, and it does, obviously cut off the nurse theorist and the part beyond that, unless you want to look at Willis's theory. But Nursology.net will actually tell you about many dozens of different nursing theories. Will give you information specifically. Some of these were written by the theorists themselves. These particular links. Nursology is an old but more recently reclaimed term for the study of nursing, the study of and the practice of nursing. And some of the core theorists are trying to reclaim that term and say the field should actually be instead of just nursing, should be nursology, particularly when you're at the theoretical and the research area. Don't know if that's ever going to happen in terms of a term for our field. However, I wanted to give you an explanation of what nursology itself means and to point you to this resource. So what are components of theory? You know you've got grand theory, middle range, single domain. But when you look at the components of theory, you're coming up with constructs, which are huge, hence this inverted triangle, and they're very theoretical and abstract. Then you've got concepts. Concepts can be operationalized, and that is brought into a measurable way. So a concept could be considered pain, and you would say pain as measured by a Likert scale of 0 to 10, from no pain to most pain. That would be the type of thing in terms of operationalizing something. There's a lot more scientific ways of doing things. However, that's just a quick example. Definitions. Definitions and propositions both allow us for testing. And you need both of those things to actually test a theory. So constructs, real big, and sometimes constructs will have multiple concepts underneath them. Concepts will have definitions, and then propositions link concepts. So constructs are very broad, overarching theoretical terms, can overarch several concepts, very abstract. A way that you will see construct used when you take your research methods course is going to be construct validity. And that is, are you measuring what you think you're measuring? Now, it's a little bit of a misnomer because you're actually taking part of the underlying concepts when you're measuring this. But I wanted to point out that you will run across this in a different context. So this is just another depiction of the relationship between constructs and concepts. So again, construct is bigger. You'll have sub-concepts or concepts from that, which will then take you to variables. And variables can be also referred to as empirical reference. Now concepts, and this is something that abstractly describes or names an object or a phenomenon. Examples of concepts would be anxiety, distress, pain, resilience, quality of life. All of these things can be considered concepts because they have different broad ways of looking at a phenomenon. Now, another way of considering theory is a progression, and this is similar to Roy's depiction, but this is a little bit more focused just on theory. And you start with our meta paradigm, nursing, person, health, environment, and then you take it down to what are our philosophies within nursing, which can then take you to conceptual models or frameworks, which lead to theories, and then to empirical indicators, which are the measurable aspects of those theories. So what about conceptual frameworks? Sometimes you'll see conceptual frameworks and theoretical frameworks used interchangeably. However, I want to say and point out that the conceptual framework is actually more abstract and more multidimensional. So it seems almost anti-intuitive. However, I wanted to point this out and give you a little bit of understanding about this. Theoretical frameworks are more narrowly bound, and the issues tend to be more specific and explicitly interrelated. Conceptual frameworks provide perspective for an area of science, whereas theoretical frameworks are more descriptive, explanatory, and predictive. Conceptual frameworks are derived from unsystematic empirical observations and intuitions, or non-scientific observations and intuition. Whereas theoretical frameworks are created from theories and from research itself. So when you say intuition or non-scientific observations, it makes sense that those would be more broad. Conceptual frameworks may be tested logically, Can you argue that logically it would make sense that X leads to Y? However, it cannot be empirically tested, whereas theoretical frameworks can be. So, in summary, in this lecture, we were introduced to the broad idea of theories, why we use them, their purpose, the three primary levels of theory, grand, middle, and situation-specific, domain-specific, and then constructs, which are larger than concepts, and the difference between conceptual and theoretical frameworks. Have a good day.